Hello and welcome back. We will be continuing with the skull. So the vault, as you can remember, is the top of the calvaria. Here, there's the bregma, that is the center of the skull, where the coronal suture separates the frontal and the parietal bones, and the sagittal groove will hold the superior sagittal sinus, as you can see here. The granular pits hold these are the granular pits. They will hold the lateral lacuna and the arachnoid granulations. If you can recall from a couple lectures ago, those will reabsorb the CSF, keeping the ventricles in hydrostatic equilibrium. And the Paconian granulations are the projection of the arachnoid villi in the dural sinuses. So this is the anterior cranial fossa and is bounded by the frontal bone and the lesser wing of the sphenoid along with the pterion. And the anterior clinoid process is where the tentorium cerebelli attaches. It's a big ligament that separates the cerebellum from the orbital occipital lobes, There is the groove right back here for the optic chiasm, and then the floor of the anterior fossa is the orbital plates and the cribriform plate. In the middle is the crista galli, where the falx cerebri also attaches, and the impressions of the fossa is formed by the gyri of the frontal lobe. In it, the foramen caesium transmit the emissary veins. So here, the crista galli has a narrow slit, and the cribriform plate for the passage of the anterior ethmoid vein, artery, and nerve. And the upper cribriform plate supports the olfactory nerves and bulbs. So the medial cranial fossa holds the temporal lobes. They're bounded by the lesser wing right here of the sphenoid, and posteriorly by the petrous bone. So petrous is this like pyramid shaped bone right here. So it's bounded right here. And laterally it is held by the squamous part of the temporal bone, the greater wing of the sphenoid, and if the skull extends upward, there would be the parietal bone. So the sphenoid body contains the sphenoid air sinuses, and those also work as voice resonators. Those are lined with mucosous membrane and communicates with the nasal cavity. If anything happens, such as an infection or a traumatic blow to the face, one of the risks is a cavernous sinus thrombosis. And if a fast-growing tumor erodes the floor of the sinus, of the Vidian nerve could be in danger. And the Vidian nerve is a secretomotor nerve that innervates the nasal and the palatine glands along with the lacrimal glands. So in the middle cranial fossa is the orbital opening, and this is the optic canal where the cranial nerve 2 and the ophthalmic artery passes through. The superior orbital fissure has plenty of things passing through, cranial nerves 3, 4, 5, 6, and the superior ophthalmic vein. Mnemonic to remember what goes into the superior orbital fissure is lazy French tarts sit nakedly in anticipation. So L would be the lacrimal nerve. F is the frontal lobe, frontal nerve. T is the trochlear. S is the superior branch of the cranial nerve 3. nakedly is, pardon me, N is the nasociliary nerve, and I is the inferior cranial nerve 3 branch, and A is cranial nerve number 6, the abducens. So the sphenoparietal venous sinuses, here you go. They all drain the brain and the scalp and the skull. The foramen rotundum will carry cranial nerve number 5, which is the maxillary division, and the foramen ovale will carry cranial nerve 5 of the mandibular region and the lesser petrosal nerve, and foramen spinosum will carry the middle meningeal artery, the vein, and the nervus spinosus. Pardon me. So the middle meningeal artery is unfortunately prone to rupture, especially if you have a temporal injury. Remember when we went through the bones of the skull, and right here is the thinnest part of the skull. And the way the meningeal artery courses is that the anterior branch goes forward and it goes up. There's a deep groove, and it is tunneled by the artery for a short distance before running back. So that's generally like a site of damage, like right here. The posterior branch passes back and up across the squamous part of the temporal bone and all the way to the parietal bone, and that's where it all innervates, or supplies. So the foramen lacerum is jagged, and it is made by the petrous part of the temporal bone and the sphenoid. The inferior opening of the foramen lacerum is filled with cartilage and fibrous tissue, and through that, small emissary veins and the greater petrosal nerve will pass through. The carotid canal will open into the foramen lacerum, and the internal carotid will enter and turn up to reach the sphenoid. The impressio trigemini is just where the trigeminal ganglion is held. The petrous port is right here, and the sulcus for the greater petrosal nerve will carry the branch of the facial nerve. It will enter the foramen lacerum and join the deep petrosal nerve to form the Terrian canal, and that will hold the Vidian nerve. The sulcus for the lesser petrosal nerve and the branch of the tympanic plexus will pass through, and the lesser branches will pass forward to the foramen ovale. So here's the groove for the petrosal nerve, the foramen ovale, foramen spinosum. So it is like right in this like almost like a triangle right here. So this would be the foramen lacerum, and then superior would be the ovale, then the spinosum, and then this would be the groove. So this is the sphenoid body. This is the sigmoid sulcus for the sigmoid sinus, the mastoid. Here's the petrous. Here's the clivus. So the arcuate eminence is usually in the anterior petrous bone. Here you go. And it makes a space for the superior semicircular canal. And the tegmen tympani, the thin bone right here. And it's just the forward extension of the petrous part of the temporal bone, and it adjoins the squamous part. And it forms the roof of the mastoid antrum, the tympanic cavity, and the auditory tube. And here's the trigeminal impression, where it houses the trigeminal ganglion. So continuing the sphenoid, the front is the sulcus right here, the sulcus chiasmatis. So that's where the optical chiasm will like desiccate. And posterior to that is the tuberculum cellae, right here. And then the body, the sella turcica, that holds the pituitary gland. And the superior angle of the dorsum cellae will have the posterior clinoid process, and those serve as attachments for the tentorium cerebelli. So the cavernous sinus here, the complications is that if you have the maxillary sinusitis, it might travel. As you can see, it's pretty close, and then it can cause like a clot. And that is pretty terrible because the cavernous sinus carries the nerves, cranial nerves 3, 4, 5, the versions 1 and 2, and the internal carotid artery and the cranial nerve 6 pass forward through that sinus as well. So if there's a clot there, it's going to be bad news. So the posterior cranial fossa holds the cerebellum, the pons, and the medulla oblongata. It is bounded by the petrous bone and posteriorly by the squamous bone of the parietal and the occipital bone. And the floor is the basilar part of the occipital bone, the condylar, and the squamous part of the occipital bone, and the mastoid. And the roof is the tentorium cerebelli. And I said it before, but let me just repeat it. It's between the cerebellum and the occipital lobe. The foramen magnum, it carries the medulla, the meninges, the spinal parts of the accessory nerve, the vertebral vessels, the spinal arteries, and the basilar veins. And right here would be the hypoglossal canals that transmits cranial nerve number 12. And the jugular foramen, right here, that will be bounded by the petrous and the condylar bone, and that transmit cranial nerve 9, 10, 11, along with the posterior meningeal artery and the sigmoid sinus. So internal acoustic meatus will pierce the posterior petrous, and that will carry cranial nerve 7 and 8. The internal occipital crest and the internal occipital protuberance is what holds the falx cerebri intact over the occipital sinus. So the transverse sulcus continues onto the mastoid temporal as the sigmoid sulcus. So here's the sigmoid sulcus. It just kind of transforms and then all drains into the internal jugular veins. The superior petrosal sinus runs backwards into the upper petrosal groove and then drains it back into the sigmoid sinus, and then all of it drains into the internal jugular vein. Fractures. So the fractures of the anterior cranial fossa usually involve the cribriform plate, which can be damaged, and that would involve the tearing of the overlying meninges and underlying mucoperiosteum. It would cause like a nosebleed and a cerebrospinal rhinorrhea, and the fractures involved in the orbital plate will cause, like here, these raccoon eyes, right? So that's the periorbital ecchymosis, but no blood will be in the eye unless there's like direct trauma. The frontal air sinus, here you go, can also hemorrhage into the nose. You see here, they're abnormally large, they're all filled with blood. So the fractures of the fossa, the medial cranial fossa is a common fracture. It's the weakest part of the base. It's caused by the presence of the foramina and the canals that will weaken the structure. And it also has the middle ear cavities and the sphenoidal air sinuses, which are vulnerable to fractures. Leak from the of CSF and blood out of the ear is common. Here you go. This is the hemotympanum. So there's blood behind the tympanic membrane. And cranial nerves 7 and 8 can be involved in the temporal injuries. And if the lateral wall of the cavernous sinus is torn, cranials 3, 4, and 6 can be damaged. And blood and cerebrospinous fluid will leak into the sphenoidal air sinuses and into the nose. It's not very easy to see this sphenoidal sinus, so if you need to image it, you have to ask the patient to open their mouth. So basilar skull fractures are hard to identify because the bruise may not show up until later. It's characterized by these symptoms. So you get the raccoon eyes, the hemotympanum. Battle sign is the big ecchymosis behind the ear. And then there's going to be some CSF autouria, so CSF leaking out of the ear. The mucous membrane of the roof of the nasopharynx can be torn, and if any of the fractures affect the jugular foramen, cranial nerves 9, 10, and 11 can be damaged. So in babies, their skulls are a bit different from ours. They still have these soft spots called fontanelles that expand, allowing the child to grow. Newborns and babies, their heads develop much faster than their body. So these stretchy points, the fontanelles, allow the cranium to expand. Over time, they're replaced with bones. The posterior fontanelle will close and be replaced with bone at around age 1. And the mastoid process, as you can see here, this one doesn't even have a mastoid process. It will form in response to the pull of the sternocleidomastoid. And the mandible is developed in 2 parts, and that it unites in the midline with fibrous tissue, and it fuses at the symphysis menti by the age of 1. All right, thank you for your attention, and good luck studying.